Our next speaker is Dr. Craig Spencer. He is the Director of Global Health in Emergency Medicine at New York Presbyterian and Columbia University Medical Center. As a survivor of Ebolavirus disease and director of a busy emergency health unit in New York City, Dr. Spencer knows firsthand how difficult it can be to take care of yourself while caring for others. In this next presentation, he will share his experiences and give some advice for how health workers at all levels of public health and clinical care can care for themselves in the midst of emergency contexts and beyond. And it's a privilege to have you with us, Craig, today. And I know you are active on social media and have had to bear some of that divisiveness in our communities as you speak truth to power and speak truth to science and truth to healthcare. So I want to hand it over to you. Thank you so much again for taking the time out of what I know is a very busy schedule to be with us. Welcome.
Thank you so much. I appreciate it. And thanks for having me. I'm really excited to chat. I'm going to just share my screen here. And I just want to play a couple slides, beginning with here. Again, thanks everyone for tuning in, and thanks for giving me this opportunity to talk with you today. Just move this around here. So you should be able to see that. You're able to see this now, my slides.
Yes, very well.
So the first thing that I want to do, hopefully this works, I'm just, as soon as I click to the next slide, it's just going to play a very, very short clip, and I'll explain a little bit after and why I wanted you to see that. For me, it's still hard to watch that. I've seen it many, many times. That was a short clip that was made by Al Jazeera Plus a couple months ago, based on something that I had written in the end of March and early April. We're here to talk really about how we kind of protect ourselves physically, how we take care of ourselves from a mental health perspective during events like COVID and Ebola and other challenging public health crises. And I don't know that I have, a magic bullet. I don't know that I have the perfect way to do so, but I do know that the way that I have tried really over the past few years, from my time working in Ebola and my time working here in New York City during the surge of COVID cases in March and in April, the way that I've tried to protect myself, both physically as well as from a mental health perspective, has been to share. And the way that I started doing that earlier this year was by sharing publicly, by sharing my personal vulnerabilities, our experience here, so that people could understand what it was like for frontline providers, for doctors and for nurses and for respiratory techs, who were really in the middle of this surge of cases of COVID, when we were overrun, when our emergency departments were full of patients on ventilators, when we'd have multiple people die every single day, and when we were being asked to do things that, quite frankly, we don't do. I'm an emergency doctor. Our goal, our job is to save lives at all costs, really. Anyone that comes in for whatever reason, our primary goal, our primary job is to stabilize, is to save lives. And what we found that we were having to do pretty early on was to think about what it meant for people, what it meant for families, what it meant for others who were watching their family members with this really horrible infection, and how could we preserve their dignity, and how could we preserve the best parts of their life without necessarily causing undue harm. And so we learned a lot. I learned a lot about how to talk to families. I learned how to talk to colleagues about kind of what we were seeing and the stress that we were under. And really, for the first time, I think ever, I turned off multiple ventilators in the emergency department and stood by and watched a life pass, as opposed to doing everything that I could to save it. But in that process, obviously, there is a huge mental burden, and that mental burden ultimately adds up to a huge physical burden. I'm going to talk a little bit about my experience in West Africa, things that I had learned then while taking care of Ebola patients, what I learned as a patient myself, and then what I carried over into working on COVID-19 in the front lines here in New York City. When I talk about my experience with Ebola, it's interesting for me because I really didn't talk about it all that much up until the past few months. In 2014, I was asked to be part of Doctors Without Borders Ebola response in Guinea. I reluctantly said yes, talked to my family, who thought it was probably an important and a good idea, given how the trajectory of the epidemic there was worsening, and ultimately committed myself to working as a clinician in an Ebola treatment unit in Gekadu. And at that time, I know a lot of people were scared. I'm sure many people on this call were involved, were taking care of patients as well. It's impossible to deny that we weren't afraid. It was a disease that had 60 to 90% mortality. We were seeing kind of horrific images of what it was doing to communities and what it was doing to people dying at the doorsteps of treatment centers. And it was hard not to be kind of worried, especially worried about yourself during that time. That being said, I was working for an organization that had massive amounts of personal protective equipment, that had never had one of its international staff or even one of its national staff infected while working in full personal protective equipment. So although there was this theoretical risk, it had never actually borne out in reality, and that made a lot of us a lot more comfortable. And that was great until basically just moments before we got on this plane, and this is a plane that took me from Paris to Guinea. We had heard about the first infection in a Doctors Without Borders staff member, someone that was working in Liberia, had become infected at some point, and we didn't know exactly what happened. And a lot of people were basically asked, do you want to go? Do you want to continue to go? And some people said no. It was jarring. It made real that potential risk that had really been theoretical up until that point and was now an actual concern for so many. And despite that, myself, along with some other friends, decided that we were going to continue to go. But this was really, in addition to kind of the mental burden many of us had already been facing, this was just another thing to add on top of this. The fact that we weren't inevitable and that we weren't uninfectable, and that coming back home without the virus was not inevitable. So this is a plane that we got on. I arrived in Gekadu a little bit later after a long plane flight and a long drive from the airport. And this was the Ebola treatment center that I was working at for the span of 6 weeks. And again, as many people here who have worked in this outbreak can attest, it is physically exhausting work every day, 10 to 12 hours with, trying to go in maybe 3 or 4 times at an hour at a time in the hot sun. You lose a lot of fluid, you become very dehydrated. It's just really hard doing all that work, carrying all those things in personal protective equipment. And in a sense, I complain about it, but I was there for 6 weeks, and most of the people I had been working alongside had been there for 6 months, including all of the Guinean physicians and the nurses. So although it was exhausting for me, I can't even imagine how difficult it was for them, especially given that they were seeing not only the same patients I was seeing die, but their community members and their friends. This was kind of the nice, beautiful, idyllic place where we were stationed. Everything looks quite nice and calm. You see a lot of green, you see a nice little road. We had our house here on the left, but straightforward, right at the end of this road was our Ebola treatment center, where every day we would get more and more patients. I was there in September 2014 as really the outbreak increased substantially. And we never got to the point where we had people, at our center's door without a bed, but we got quite close. And we had those discussions because the increase in cases was substantial every single day. This was a team that I worked with, or really the team that worked with me. Dr. Keita and Dr. Mode are just absolutely incredible physicians. They're both infectious disease docs in Guinea, and I had never taken care of Ebola patients before this, neither had they, but they had been there really since March and April of 2014, so over 6 months, and taught me everything that I eventually learned about Ebola virus care, especially in a context like this. They're absolutely wonderful. And this is really just the process of putting on the personal protective equipment. I'm sure for anyone that has done this either for Ebola or has done this for COVID, you recognize that, we can do this individually, but when we are working in outbreaks like this, none of this is actually an individual effort. It needs to be a team effort. And so in terms of, one of the tips or the tricks that I had learned early on that prepared me and helped prepare my colleagues for this COVID-19 outbreak in New York City was just really simple things like having a PPE buddy, someone that you could trust to let you know whether or not your personal protective equipment was continuing to protect you even after you had put it on correctly, making sure that you look okay, but checking in every 10 or 15 minutes once you're inside a treatment center as well. And for me, this ultimately became second nature. This is something that we did every single time we took care of patients in West Africa, and it was something that a lot of my colleagues here in New York City didn't know because they'd never been in that scenario. And so in addition to, I think, the importance of us as kind of a global community responding to global public health threats wherever they happen, you get the added benefit of experience in being able to be prepared for when that outbreak or a different outbreak comes to your front door. And so I learned so much from my experience in West Africa about how to protect myself and how to protect my colleagues. And I'll talk a little bit about how that translated into my experience here in New York in 2020. Despite using PPE every single time and having a PPE buddy, I unfortunately, as has already been mentioned, was infected with Ebola myself. At some point while taking care of patients, people always ask how did it happen. I say I have no clue. Probably in the process of taking care of hundreds of people who were really, really, really sick with Ebolavirus. Myself, in addition to the nurses and the other staff that was trying to provide some dignity to many patients near the end of their life who were too weak to walk or to move or to drink or to eat. It was a really intimate and risky endeavor, and the majority of my colleagues walked away without being infected, thankfully. I however had the really unfortunate displeasure of being sick and fell ill once I was already back in New York City, I guess maybe 10 days after my last patient contact. I learned a lot from that. I learned obviously the humility of being a patient and what it's like looking up at a provider as opposed to being a provider and looking down. I learned about really the mental health unease that our patients feel and face in really when faced with this illness that is incredibly dangerous and deadly. And it taught me a lot about how to be a better provider. In a few months after I got out of the hospital, I tried to capture kind of some of that anxiety that had gnawed at me when I was taking care of patients and then when I was a patient myself. And really the only thing that I could come up with was basically this kind of daily sensation or daily worry whether today was the day that you got infected. Even if you use your personal protective equipment as intended and you're really good and you have a good PPE buddy, you just don't know. And not knowing is one thing, but knowing that you're not going to know whether you're infected for another week or maybe 2 weeks, depending on the incubation period, was one of the hardest things for me. And I know all of us counted our days after our last exposure to know when we were actually finally free from worry. But for some of us, that never came. And in the same piece, I talked a lot about kind of the anxiety and how it manifested as physical symptoms. So in addition to just kind of stress, this feeling that maybe I had something wrong with my stomach, that I had gastritis, or I had an ulcer, or I had something else going on. Never in my life had I experienced such kind of mental unease translating into such profound physical symptoms and physical unease. I knew it was certainly possible, but I'd never experienced that myself. So I think there's this huge connection, obviously, between the stressful situations we put ourselves in, our ability to, and I think everyone here, either as a healthcare provider or someone working on the front lines, our willingness to help others puts us at risk and puts our own physical health and our mental health at risk. And it's quite easy for us to get lost in how potentially impactful that can be and how we necessarily need to always best protect ourselves. And so I want to translate a little bit of that learning into what we saw here in New York City during COVID-19. As I mentioned, I was working in an emergency department here. I have been working here for, I guess, over 13, it's my 13th year working in an ER in New York. And when COVID was really first discovered and first announced, and we started seeing cases really all around the world, I had a really significant fear that it was going to come to the US. I feared that because, one, New York City is obviously a huge global destination. It was only a matter of time. I also feared it because for a really long time, the United States had really prided itself on how well, or at least how well we thought we were prepared for a pandemic. But as someone that had been, especially after 2014, had been immersed in that world, that had understood the role of pandemic response in the US and had seen how a lot of our pandemic preparedness architecture had been torn apart or undermined or underfunded in the past few years, I was quite concerned the impact that it would have. Never did I imagine it would be as bad as it was. And I was actually quite surprised it took longer to arrive than it did. It was in March 1st, when we had our first announced case of COVID-19 here in New York. The virus likely had already been circulating for some weeks. And really within the span of the next few weeks, we would go from everything basically being normal in our emergency room, around middle of March, maybe having one patient that had COVID, to a week later, basically every single patient in our emergency department being COVID, and making it really hard to find the one person who was not there for a COVID-related reason. And it overturned so quickly, really within the span of a week, maybe a week and a half. I mentioned how my experience in West Africa helped prepare me for this. I didn't really realize how much that was the case early on. As I mentioned, a lot of what we did was just kind of second nature for me, right? Putting on personal protective equipment and doing it right. Recognizing that personal protective equipment is great when you have it on, but it's actually the riskiest when you take it off if you don't take it off correctly. Thinking about how we limit our personal exposure and we limit the exposure of others. So limiting the number of people that go into a certain space. All of these things that I had learned or had been taught really by Dr. Keita, by the nurses in the Ebola treatment unit, everyone in West Africa, that was stuff that I was able to translate to our experience here in the US, although I never expected to be able or to really have to do so. There was obviously the physical demands were the exact same in that there were long shifts. It wasn't outside in 90-degree heat, but it was still extremely difficult and challenging in personal protective equipment that many of us are not used to wearing, especially in ERs in the US. And I was really worried about the physical demands and what people were going through, but I was really worried about what would happen once kind of the mental health impact eventually added up. And I say that because every single day, one of my colleagues would call me crying, worried about themselves, worried about their health, worried about the things that they had seen. They would be crying because, many of them said, where we want to help people, but this isn't necessarily what we signed up for, but we'll definitely show up for this every single day. And the first thing that I reflected back on was my experience in West Africa, and it felt so much the exact same feelings as I felt then. And once I recognized that, I felt kind of a lot more emboldened and capable of helping my colleagues here in New York City. I think the parallels were similar, not just for the physical, but of course for the mental health. And this was something that we were able to share really amongst our group on kind of team meetings. And I think that it was quite helpful really early on for me to have a role in terms of sharing that information. I think it was quite helpful for all of my colleagues to know that there are other people that have had the experience like this and know what the mental health impact of it is. But even so, that's only so helpful when providers are doing and seeing things on a daily basis that they've never been forced or never had to do before. And I think, as I mentioned with my experience in West Africa, how that kind of that mental anxiety really built up on a daily basis, eventually manifesting itself with physical symptoms. And I mentioned how, every single day I would get a call from one of my colleagues, just really worried about themselves, whether they should still be at home with their family, whether it's too dangerous, whether their symptoms might be just a regular cold or whether they have COVID and what is going to happen with them, hearing about health, complications that I had never really known about from my colleagues because they were concerned about their risk. It was a moment, I think, of really difficult stress, but it was also an incredible moment of solidarity. I wrote this piece in April around the same time, and it's called "How Long Will We Doctors Last?" But it was really for basically every single healthcare professional that I was working with on a daily basis, and it outlined all of what we saw, all of that stress, all of that anxiety, the mental anguish of watching on a daily basis and seeing people die when our job was to do the exact opposite, to save lives. And my concern that over the longer period, providers were going to have a really, really hard time, and that this would have a long-term impact on our ability to not only care for ourselves, but to care for others. I'm sure for many of you, and I know that this was mentioned in the intro, a lot of us lost friends. We certainly lost patients, but we lost friends and we lost colleagues. All throughout really March and April, we dealt with a lot of really scary scenarios with colleagues of ours who got infected. I remember working one day in the emergency room and getting a really frantic call from someone that one of our residents, one of our trainees in the emergency department was coming in, and he was quite sick. And they mentioned this because I guess he had been exposed and maybe had symptoms a day or two prior, hadn't been at work, but now was really, really bad. It was a young person, very, very healthy. And I went out to meet them in our waiting room. And as soon as I got out there, I was just taken aback by how sick this person was. Someone that I was used to seeing extremely well, extremely healthy, extremely happy, always with a smile on his face. Now was really struggling to breathe, struggling to stand. And your instincts kick in, both as a provider, but also as kind of a friend and as a colleague, and you want to do everything that you can. I just remember kind of my heart beating so fast, despite having done this at this point hundreds of times with other COVID patients, and thinking through the steps. What is the right thing that we need to do? Get them on oxygen, get them in a get them in a seat, get them in a chair, and then think about slowing your breath down with theirs. And despite how frequently, how often we do this, when it's your friends, when it's your colleagues, it hurts, and it's so much more painful and so much more visceral. In just a few days after this happened, we had lost one of our nurses who had been on a ventilator for COVID-19, and it was the same person who, once I started at this hospital 9 or 10 years ago, had showed me around, had introduced me to a lot of the staff, someone that I'd seen hundreds of patients with in the span of the past decade. And he, like so many of the other nurses that were working on the front line, had been infected, and unfortunately he passed. And this was really, really tough for all of us. This was right in the middle of when things were really bad. We had already had that physical strain of working a lot, of being really exhausted. We had already had that buildup of that mental strain of seeing patients die every single day and feeling hopeless, not knowing what we need to do. Should we turn people over? Should we give them these medications? Should we try different medicines? And then on top of that, losing your friends or losing your colleagues, losing the people that you work with over a long period of time is incredibly difficult and incredibly painful. I just wanted to show a slide here because I think this was one of the more painful ones for many of us. Dr. Lorna Breen was a colleague that worked with us in the emergency department. Someone that I'd known since my first day, someone that I'd gotten to know pretty well. We chatted, at work every time we saw each other for quite some time. And Dr. Breen's family has really been doing a lot of advocacy around the issue of mental health in physicians and healthcare professionals. Dr. Breen was in charge of one of the hospitals here in New York City, really during the worst of COVID. She had gotten and survived COVID herself, and had continued, after she convalesced, to come back and take care of patients. And a few weeks after having coming back, she took her life by suicide. And I think for all of us, this time was incredibly difficult and incredibly hard. Losing friends, losing loved ones, losing colleagues. And her loss, I think, has just really highlighted the huge toll, the huge impact that seeing and doing what we do as healthcare providers on a daily basis is so painful and so hard. And that it's also, in places like the US, it's potentially a detriment, and it's potentially a challenge to, your license for people that speak up and mention their healthcare or their mental health history. It can result in losing your ability to practice. And so there is an advocacy push. I think that there is around Dr. Lorna Breen and around so many others who have been directly impacted by the mental health impacts of this crisis. There is a push to recognize that just because we're healthcare providers, just because we work on the front lines and we can do this really difficult, physically exhausting work, we can see people die and shake it off and go on and take care of the next patient. Just because we're all capable of doing that doesn't mean that's what we need to do. We also need assistance. We also need help. We also need outlets. We need people to feel vulnerable with as well. And I think this was one of the biggest things that I tried to share with my colleagues really early on when they'd call me crying, when I heard about really how the mental health toll was building up. We all need someone to be vulnerable with. And as healthcare providers, we often are that person. We're the person that others are vulnerable with, the ones that can share, their worries, their healthcare issues, their stress, and we need that as well. And so the one thing that I've really found that's been helpful for me, and that was helpful for a lot of my colleagues during COVID, was just finding someone that you trust, that you can be vulnerable with. And with that, I just want to say thank you to everyone, especially to all the nurses and everyone else that has been taking care of patients through this and through really all of the other public health crises we faced over in the past. Thank you so much.
Thank you, Craig. It's really a privilege and an honor to have you with us, to share your story, and in many ways a healing narrative of how you have, as you said, go in at all costs, and yourself knowing very intimately what those costs are, physically, mentally, maybe spiritually, and in the impact on yourselves and colleagues. I was struck when you said, you were in West Africa for 6 weeks. I felt the exact same way. In my early days, I worked in Southern Africa, in Zimbabwe, for 2 years during
Mhm.
the height of the HIV crisis. And it has affected my whole life, and is why I am such a strong advocate for health systems and for protecting the health worker. It was risky. I didn't have HIV, but I had probably over 100 needle stick injuries. We had to use our gloves. We had all of this, and the hardest part of it was going back 2 years later. And many of our nurses were gone. They had died of HIV. Yeah. And I had the privilege to leave and to go on and to study. Right. And that sits with me throughout my entire life, that dissonance. And I feel we are compelled to speak, and I know you do as well through social media and through the literature, and you do it so beautifully. We have a number of questions coming in that I would like to ask. And one thing I would like to start with is this idea of solidarity that you spoke about. Somehow, in the midst of crisis, all the hierarchy and the divisions between professions and between communities and between all systems of government that have to come together to make this happen. Somehow, much of that during Ebola just fell away, and we were all hands on deck. We were all together. Right. And I remember when I was in West Africa with WAFA, and we said, we've never seen this type of relationship before in our work. There's always this, rivalry or these lanes we stay in. And that was gone. And we were just all working together like a choir or an orchestra, just all in it together. And there's a in that. And I just wondered if you could comment on that while I pull up the other questions.
Sure, of course. Yeah, and I completely agree. I mean, I worked for an organization, Doctors Without Borders, where, really at baseline, nurses are often in roles above doctors. And I think that we're often reminded of that. But I think that even that kind of that normal hierarchy that we're used to, especially in places like the US or in other organizations, did just fall away in West Africa. Working together with my colleagues, all of us as equals, I think was the most important way for us to share information and to do our job well. I think the one thing that we could have done better in West Africa, and I think that likely relates to some of the questions that might be coming up, is really our engagement of the community. And, us working together as healthcare providers is great. Healthcare providers treat healthcare threats as, biomedical issues, as opposed to ones that have greater sociocultural or anthropological impacts. We're seeing this with the similarities to what's happening with COVID-19 in so many places. Here in the US, we maligned people in West Africa for not taking Ebola as a real disease and calling it a hoax. And so much of what was done there is being done here. And I think really what it just shows is that we're not all that different. We're all very similar, especially in the ways that we respond to things like this. And that we as healthcare providers need to be in tune with not only what we need and how we need to help ourselves and break down those hierarchies, but make sure we're involving communities, make sure we're involving decision makers and other people in those communities that are either spreading misinformation or don't completely understand why it's so important to adhere to the public health guidance. That has been a huge issue, and that's been something that I think I and many others have really been frustrated and challenged with during COVID-19.
A very wise elderly man said to me after I got back from Sierra Leone, and I was frustrated at the lack of engagement with the community. And he said in the 1940s and 50s, he was taught in the US Health Service that the first thing you do is you go and talk to the leader in the community as you go into a crisis. And there is great wisdom in that. I want to, in the interest of time, get to some of the questions. I have one from a colleague, Pule Mwabe. Soon will be Dr. Pule Mwabe. He is a nurse educator in Lesotho and runs simulation training there, a lovely young man. And he asks, thank you so much for sharing your story. Based on your experience treating Ebola patients, what advice can you give to healthcare workers caring for COVID-19 patients as some are experiencing mental and physical fatigue? What would be your advice for them?
I think just knowing we have limited time here, I just want to make sure that what I would say is that, making sure you have both physical and kind of mental health concerns in mind. So making sure that you're taking adequate breaks, making sure that you have a team that's able to share kind of the burden. You're not doing it all yourself, that you're able to kind of swap out, and that you're able to do it in an environment where you're continuously and always protected, and really to never compromise on that. But I think really from the mental health perspective, I think having someone that you can be vulnerable with, someone that you can share really all of your concerns. Hey, I don't feel like this is safe, or I'm worried about taking care of this one patient, or I'm worried about maybe I was potentially exposed, or what would happen to my family if I was. I think having someone where you can talk to talk about these issues, I think is absolutely critical. We don't do it very well as healthcare providers. We take a lot of this burden on ourselves, and we need to share it with us. And I think that would be the biggest thing that I've taken out of my experience that I would like to share with others.
So allowing yourself to be vulnerable and to reach to others.
Yeah, for sure. Absolutely.
Okay. We have another question. Another person, thank you for sharing your story. Could you share how you dealt with public skepticism of Ebola severity at the beginning of the outbreak, and the lack of community engagement, or the engagement where people said they didn't believe in it? As we've seen in the US with COVID-19, especially people not wearing masks, and still, as the numbers continue to go up in many areas, not wearing masks. Right. How did you deal with that public skepticism, and how do you deal with that today?
Yeah, I mean, the way that I did deal with it is I don't think that I completely understood how prevalent it was, or really what the underpinnings, the roots of it were. What I'm realizing more and more, and what I really appreciate, good public health communicators and science communicators on, is understanding that shaming people is not going to work. Yelling at people is not going to work. The only way that you're going to change behavior is to sit down and have a discussion, or to completely understand why people are doing things or not doing things. We've had this discussion around masks in the US. This has been crazy over the past many months, because we know that they're super helpful in preventing the spread of COVID, but many people refuse to wear them, either as a sign of kind of partisanship, or because they don't trust the science, or for many other reasons. And there has, I think, been some work that's been done showing that once you take this and you frame it not necessarily as an individual, but as a community level intervention, something that can help just not that one person, but their family, focusing it on them as well as everyone else, that will likely increase adherence. That will likely increase people's ability and willingness to go along with public health guidance that may have otherwise been misunderstood. But I think the most important thing is sitting and listening and understanding, as opposed to pointing fingers and shaming, which almost never works and only makes things worse.
Right, which can be very frustrating during times of crisis, make it increasingly difficult. But I completely agree. We all act out of complex emotions and fears and understandings of what is right and wrong. And I think it points to the critical importance of leadership during times of crisis, and to be that person who is able to be the calm in the storm, and to say, this is what will protect us all. And the whole narrative about masks could have been completely different. It could have been as a patriotic act for not only yourself, but for everyone else, as you said. Another question I have through my counseling, if I could grant you a wish in fantasy right now amidst COVID-19, what would that be? What would that wish be?
My wish would be that we take the partisan out of public health, especially here in the US. We have one kind of cohesive response versus 50 separate, and that we give our public health providers and our frontline professionals the ability to, and really the capability to speak and interact directly with the public, and a public that, kind of appreciates and understands what we do, but a public health providers that can understand and are willing to listen to people themselves and understand their concerns, and have a forum in which we could directly discuss that without, without the, I think the rancor of social media, or without the partisanship of so much of the discourse. So I would take the partisanship and the politics out of public health. That would be my wish, as much as possible. I know it's not completely possible, but
I completely agree. And there are
yeah.
studies showing that partisanship is the biggest driver of mask wearing. And
Yeah.
it's really, they
Sure.
strange bedfellows, politics and public health, and we need to somehow disentangle them for all of us, for the good of everyone.
Right, for sure, absolutely.
Thank you so much.
Thank you.
I know you have such a busy schedule, and you've reached many people from all over. We have people from Rwanda, Lesotho, Botswana, from throughout the United States here with us today. And I really thank you for sharing your story and for staying in this work when it is really hard. It's a marathon, not a sprint. And your resilience speaks volumes to us as providers, but also to the general public of what it takes to care for the world and for our communities. So thank you.